Hey all, I'm back, another podcast, and this one's going to be on NPO and procedural sedation for emergency or for emergent procedures in the emergency department. And I decided to do this one because this has come up a couple times in the recent past where anesthesia and ER may have differing opinions on whether a patient should be done due to NPO status. So I figured this would be an excellent one to do. Hope you like it. So let's talk about elective versus emergent first. Um, Many of the things you do in the ER are urgent/emergent that really do need to be done. Can some of them wait? Yeah, probably, but it's really unfair to make a child wait 6 or 8 hours that has a simple laceration or a simple IED or an adult with a fracture or whatever. You get my drift. And some of them really have to be done. A hip dislocation, you cannot make wait. Shoulder dislocations, you can't make them wait, etc. So this is a whole different ballgame than an elective case that's scheduled in the OR. The ASA specifically says that the NPO guidelines are for elective procedures only. Let me repeat. Their guidelines, the NPO guidelines, are for elective procedures only. The ASA in 2011, they came out with their first non-elective NPO guidelines. They're really unclear and so forth, so on. Kind of left it up to judgment and a lot of gray areas. So in 2018, they came out with new non-elective NPO guidelines. And basically what they say is in urgent or emergent situations where complete gastric emptying is not possible, i.e. they don't meet NPO guidelines, do not delay moderate procedural sedation. So, I mean, you get a cardioversion in, and he ate 2 hours ago at McDonald's. You can't make him wait. You can't um, um, not do him without any sedation. You really, I mean, wouldn't recommend intubating and inducing a patient that only needs cardioversion. Hip dislocations, fractures, shoulder dislocations, INDs, talked about those. So these are all things that need to be done. You're in a rural ER, and you do a lot of things that a rural ER as anesthesia and as ER providers. So you get a patient with a cardioversion that is, blood pressure of 85 over 40. Personally, I'm not going to induce that patient and intubate them. I'm going to give them a little Versed, some ketamine, and cardivert away. Moderate sedation, in other words, no matter what their NPO status is. So CMS requires anesthesia oversight in all areas of the hospital. I've heard a number of people say that the standards are different if you're anesthesia or if you're an ER provider or if you're a radiologist or whatever, and that's simply not true. The standards are the same for all. Anesthesia oversees it all, and there's not a different set of standards for one provider over the other. And I just want to pop up this. This is from the ASA NPO guidelines. And you can see here what they say. This intended patient population is limited to healthy patients of all ages undergoing elective procedures. Cannot tell you how many times I hear anesthesia people say, well, but the NPO status, blah, blah, blah. It doesn't matter. If it's urgent or emergent, the NPO status doesn't matter. Your decision from that point is, are you going to intubate, induce an intubate, or are you going to not and do something else? Personally, I am a big fan of blocks in the ER, and I do the vast majority of mine under block anyway, but sometimes you still need to sedate, or a child that comes in that you need to sedate. Here is the cutout for the new practice guidelines from the ASA, came out in 2018 for moderate procedural sedation. Note what they say. In urgent or emergent situations where complete gastric emptying is not possible, do not delay moderate procedural sedation. It's very plain, very black and white. And it's not just the ASA. This is a task force made up of a bunch of different organizations, and this is what they've come up with. So I talked about these a little bit. The ASA consensus-based guidelines, preoperative fasting. healthy patients undergoing elective procedures. So obviously these exclude ED patients. Separate guidelines that they talk about, basically saying the literature doesn't provide sufficient evidence that pre-procedural fasting results in a decreased incidence of adverse outcomes, meaning aspiration. And there really isn't. I challenge you to show me literature that shows increased complications, meaning aspiration, in moderate sedation. They go as far to say deep sedation. I won't go there, but I will say moderate sedation. And again, in 2018, urgent emergent situations don't delay. So these guidelines that they came out with in 2018 apply to moderate sedation analgesia, as previously called conscious sedation, procedural sedation, etc. And obviously they're going to help the various practitioners. We want to decrease the risk of, obviously, patient outcomes. And evidence is where it's at. We all practice according to the best evidence available. And there's such a huge amount of evidence. But it seems that my anesthesia colleagues, some of them have issue. I'm not sure if they're just not up on the evidence or stay current on it or what, but there is just ream after ream after ream of it. So these guidelines came out, and they are specifically say, the ASA specifically says that these guidelines are intended for use by all providers who perform moderate procedural sedation in any inpatient or outpatient setting, anywhere in the hospital, any provider, anesthesia provider, could be a medical doctor anesthesiologist, could be nurse anesthesiologist, could be anesthesia assistant, although I think they're mainly the ORs. They don't get down to ER much since they have to be supervised. ER physicians, you name it, they're for everybody. You notice it doesn't say there's two separate standards. It doesn't say, well, this is for anesthesia, this is for the ER providers. So for my people who think there's two different standards, there's not. There's one standard, it's applicable to everyone, and that's directly from the ASA. And again, from the ASA, I know I keep harping on this, but if you can see the arguments going back and forth, it's just ridiculous. In urgent or emergent situations where complete gastric emptying is not possible, do not delay moderate procedural sedation based on fasting time alone. This is from the American Society of Anesthesiologists. Obviously, you're going to make a judgment call. Is the patient, able to wait, etc.? Are they 400 pounds and have other issues that maybe you want to intubate or whatever? You get my drift. But the vast majority of patients you're able to do under moderate sedation without inducing and intubating them. The stakeholders all agreed. They did 4 different groups in this 2018 statement that the ASA came out with. And again, I'm not going to bore you with reading this over and over, but they all agree, do not delay moderate procedural sedation based on fasting time alone. So what does ACEP say? The American College of Emergency Physicians. They also have guidelines and a consensus statement, and they have a bunch of other organizations that came out with them. And their statements and guidelines basically mirror what the ASA says. So talk a little bit about what they say. They talk about that they found only 9 reports of aspiration-associated deaths, and that's since 1984 in the procedural sedation literature. And 8 of those were during EGDs, which I tend to dislike greatly. None of these were in children, healthy adults. And currently, they say there's no evidence that noncompliance with elective fasting guidelines increases the risk of aspiration or other adverse events. And talks about the providers of this unscheduled, meaning emergent, urgent, should assess the timing and nature of recent oral intake. Obviously, again, they talk about making judgment decisions, whether you need to secure the airway or not. And they talk about when you can't delay, consider the use of ketamine which obviously preserves protective airway reflexes. And they say there's been no reported occurrences of aspiration. And I have a slide later on that shows the reference to those studies, and over the last 30 years. So that's a pretty good record. And the bottom line is it's extremely safe to do moderate sedation, regardless of NPO status. There's reams of literature supporting it. And obviously, like they say, you have to judge risk versus benefit. And this is from ACEP 2013 clinical policy. And they talk about pediatric emergency department patient and NPO status. And they go through and look at a huge number of patients and studies. 140,000 procedural sedation anesthesia encounters in this data set. The NPO status was known for 108,000 patients, and of those, 25,400 were not NPO. They had 75 major complications, 62 admissions. There were 10 aspirations out of those 25,400 cases, no deaths, and the statistics say that there's no association between, in this study, NPO status and aspiration. So that's a huge study you're looking at right there. And there's many, many more, which we'll talk about. I just hope I don't bore you. And just a quick sidebar. I love ketamine. I love ketamine in the ER. I love ketamine for kids especially. It's just outstanding. If you get a kid in and you can't block them for a fracture, or maybe they have an IED, or a younger kid that needs a quick suture done, IM ketamine is the bomb. People are doing inhaled ketamine, nasal ketamine. If you have an IV, great. But the bottom line, and I have the reference below, in the last 30 years, there's not been a single documented ketamine-associated aspiration. So that's pretty safe. I'm going to talk about the studies a little bit. Here's one done, a retrospective review, and they found over 2,000 titles for review. I mean, there's been a lot of studies on this. Out of those, 55 articles were eligible that had almost 10,000 sedations. And they found one case of aspiration in all those. Came up with 1.2 per 1,000. So, I mean, it's really excellent. This is even below the rate of aspiration you get by doing an RSI and intubating somebody. You're not manipulating the airway, and that's the key. All right, a few more studies. Hope I don't bore you. Here's a study that looked at a little over 1,000 kids, procedural sedation in the ED. 900 of them had, they knew what the fasting status was, and 509 of those didn't meet the fasting guidelines. What they found, there's no difference in adverse events between the fasting and non-fasting groups. No difference in vomiting between the fasting and non-fasting groups, and no cases of aspiration. I have seen some studies that show that the vomiting is more frequent in patients that meet NPO guidelines. This is a retrospective analysis, about 2,100 procedural sedations. The incidence of adverse events were the same whether fasting was 2 hours, 2 to 4, 4 to 6, 6 to 8, or over 8. And there were no aspiration events among any of these, no matter what the status was. Another study, this is a small one, only 257, ED, procedural sedation, no aspirations or vomiting. No statistical relationship between fasting time and vomiting, but children who fasted for more than 3 hours vomited twice as often as the unfasted children. So that's pretty significant right there. Another study, again, kind of small, 220, procedural sedation ED with nitrous, and 71% didn't meet NPO guidelines. No aspirations, no adverse events. And I put the references down below. You guys are welcome to go and read them. And another study, 471 patients, again, ED, procedural sedation. And here they looked at receiving oral medication before sedation. And technically weren't NPO any longer. And they didn't find any difference in adverse events, whether or not it was within 6 hours. Here's another one, a nice study, over 2,600 patients, ED procedural sedation. So out of those, there's only one aspiration event, and that patient had been fasting for 24 hours. So 2,623 patients, one aspiration event, and he was the only one that had fasted. And what they found, no association between time of last oral intake and vomiting or any other adverse effect. Here's another study, small 166 sedations, 78% were not NPO, and they found no increase in complications. 4.7% in the non-NPO versus 6.9% if fasted. So that was interesting. Again, you get the drift of this. I mean, all these are showing that the fasted seem to vomit more, and even the aspirations are seeming to happen in that. This one here is huge, from the Pediatric Sedation Research Consortium, and it's over almost 140,000 patients over 4 years at 42 different hospitals. And what they found, aspiration out of that huge number of patients, aspiration occurred in 8 patients who were NPO and 2 patients who weren't. And again, once again, you have a quadruple increase here in the patients who were fasted in NPO. This one here, a little over 6,000 sedations, over 50% didn't meet NPO guidelines. No cases of aspiration at all, and they found no association between time spent fasting and adverse events or vomiting. Another 17,672 pediatric ED procedural sedations and 4,657 adult ED procedural sedations. Among all of those, there was one case of aspiration, and that was in a patient who had been fasting for 5 hours and required 2 separate sedations. So again, the only case of aspiration in 22,000 procedural emergency department procedural sedations was in a patient who had been fasted. So again, obviously they didn't find any association between fasting time and any other adverse event. The ASA study and what they say, literature does not provide sufficient evidence to test the hypotheses that pre-procedure fasting results in a decreased incident of adverse outcomes in patients undergoing either moderate or deep sedation. This is from the ASA. Another study, I know you guys are getting tired of these, 400 patients, adult and peds, again in the ED, 71% not meeting guidelines. And you can see that the NPO group had a higher incidence of vomiting than the non-NPO group. So let's talk about harms. We mentioned briefly before, and you know, some of these patients you have to do, or they can have severe consequences. Hip dislocations is one obviously brings to mind. Shoulders, and just the patients themselves making a child wait for 6 hours with a lip laceration, which I've had anesthesia people say, oh yeah, make them wait 6 or 8 hours. It's like, come on, be realistic, especially when the studies show that it's extremely safe and the risk is actually less than intubating that child and doing an RSI on that child. So to my colleagues, I would encourage you to review this literature, have an open mind, and do away with this dogma. All the various reference organizations, such as Medscape, Up to Date, all support the moderate sedation without waiting for NPO status. And they all say the same thing. Here's one last study I popped in because I thought it was really interesting. And what they found is that the vast majority of aspirations occur during endoscopies. And out of these 1,250 records, 35 articles that describe pulmonary aspiration, 292 occurrences, and it was all during endoscopy. The guidelines we touched upon, all the guidelines from major organizations from ACEP, the ASA, let me repeat that again, the ASA agrees, the pediatric organizations, radiologists, oral surgeons, they all agree with the NPO or not waiting on NPO status for moderate sedations. So it's really important to point out that this fasting tradition, and it's been a white hat for years and years and years. I've been doing this for almost 30 years, and it's finally starting to change. I mean, recently it used to be 8 hours, 8 hours, 8 hours, and now we're giving patients carb drinks 2 hours before procedures. Of course, those are elective procedures, so I won't go off in a rabbit hole here. But the bottom line is that there's really very little scientific support. Those NPO guidelines are from the 50s, if I remember right. Somebody can correct me if I'm wrong on that. So very, very little scientific support. And in all the studies, literally thousands of them, say there's insufficient evidence to associate fasting time, gastric volume, or acidity with the probability of aspiration. In all the various studies of ED, procedural sedation, analgesia, no evidence at all that fasting has an impact on the incidence of aspiration. And I challenge anybody, and I'd love to see it, to show me a single study that shows this. I've provided many, and there's many, many more out there that I didn't even bother just because you guys would really go crazy if I included them all and talked about it. So even though RSI and inducing and protecting the airway with an ET tube is an alternative, you really need to weigh that and the risk-benefit patient. The airway manipulation is where most of the aspirations occur and is due to that airway manipulation. So just say no to dogma. I mean, I think this should have been pretty convincing. Have an open mind, and if you want, go in and read those studies. And please look up the ASA 2018 NPO guidelines for urgent emergent cases, non-elective cases. And I posted in there ad nauseum and repeated ad nauseum, so I'm sure you guys are tired of it. But again, even the anesthesia literature supports it. I've seen recently people talk about lawyers and lawsuits for not following NPO status for procedures, which I tend to call bullshit on that. Excuse my French. I've not seen any cases on, I'm sure they're out there, I'm not saying they're not, but bottom line is that you're going to get sued no matter what happens. And the literature shows that it's safe. It shows that there's more aspiration events when you're intubating than not. So again, I call BS. You're going to sue whether you intubate or not. The literature shows more risk of complications if you do decide to use an endotracheal tube. And again, just say no to dogma. Don't let it interfere with good, appropriate patient care. And I know this is a white hat that we've been doing for years and years and years, but things change, literature changes, and we had based our whole NPO status and guidelines before on very little to no scientific. So let me know what you think. Either way, I'm happy to debate it. If you have any actual evidence, I'd love to hear it, or I would even more so love to see it. Post it in the comments, and best of luck.